Thank you very much, Marie. It was a very superlative and lovely presentation, most of which brings back good memories, all of which brings back good memories, I should say. I apologize for my voice. I have not been partying in Istanbul yet. I got a cold the day I arrived, laryngitis. But I'm taking all sorts of lozenges. I'm taking lozenges from China, from Japan, from India, from Turkey, and I think they're starting to work. So, dear ISMICS members, dear colleagues, welcome to Istanbul. It has been a distinct privilege and my highest honor to serve as president of our society this past year. Before I begin my address, however, I would like to first thank all of the individuals who have been instrumental in making ISMICS happen this year, starting with our program co-chairs, Shaheen, Danny, Sarah on the cardiac side, and Aniz, Faz, and Alper on the thoracic side. The hard work and effort that they have each put into planning this year's program alongside our whole program committee is exemplary. So my deepest gratitude goes to them for having produced the rich program we are enjoying and about to enjoy for the rest of this meeting. Obviously, this program would not be possible without the diligent and expertly organized efforts of Ms. Britta Tyler, our meeting manager, and the help of Tiffany McCoy from PRI. So thank you to the both of you for all of your hard work. Our executive board, comprised of Bree, Nirav, York, Abbas, Nikos, and Vino, deserve thanks for providing me steadfast counsel during our monthly Tuesday vignettes, as well as the rest of our stellar board members who were essential in helping to guide our decision-making throughout the year. A special mention should be made in recognition of the success of our journal innovations under the leadership of my dear friend Niv Ad, our editor-in-chief, and our managing editor, Sari Holmes, and the whole editorial board. They have continued to reinvent our journal with new features and additions that are extremely appealing to the readers. Our journal impact factor has risen to 1.7 this year, and I expect it to continue to rise with the efforts of all the associate editors, the editorial board, and all of you who continue to submit papers and articles to this wonderful journal. A special thanks is due to Orly, Stan, Shayla, and the rest of the PRI team who kept the society running smoothly this year as in past years and have been great partners with us in this minimally invasive cardiothoracic journey of ours from the beginning. My mentors at Tufts University Medical Center, which used to be called New England Medical Center back in the day, but I'm told now it's called Tufts Medical Center. They taught me how to do cardiac surgery, and they are my heroes. Taking a novice through learning the mechanics of heart surgery, cardiothoracic surgery in general, is no easy task. And I give them all the credit in the world for teaching me the tricks of the trade and transforming me into a safe and effective cardiothoracic surgeon from day one. Doug Payne taught me how to be patient in the operating room and respectful to every member of the team. Hassan Rastagar preached respect for the tissues and to never make the incision larger than it needs to be. Bob Bojar taught us how to take care of patients in the ICU, in addition to teaching a lot of other people with his great book. And he also let me sew my first circ in the groove as a junior fellow, which was a big deal. Ken Warner was an up-and-coming young congenital heart surgeon and taught me to be empathetic towards my patients and towards their families. Ben Daly taught me the tricks of VATS lung surgery, which was the basis of my future immersion into endoscopic heart surgery and started to look at the heart from the side, which is not something you do in traditional cardiac training. Bernie Wong taught me the importance of flow in surgery, and among many other things, the importance of making sure that you have an excellent first assistant. And finally, Jim Symes, who taught me the virtues of innovation and actually let me do his first 2 mid-cap procedures as a fellow in 1996. I owe you all a ton of gratitude. The section of cardiac surgery at the University of Chicago Medicine has been my home since 2013. Without the vision and help and support from my colleague and dear friend Balkhy, our robotic program would never have flourished, as he enabled me to focus on building a unique multidisciplinary robotic program with a dedicated team from the very beginning. My colleagues on the faculty, Chris Salerno, Take Ota, David Ansago, Tay Song, Luca Vercella, and Naro Habino, were all very supportive in allowing our robotic program to flourish. And we have new additions to the program, Hiro Kitahara and Miro Piv, that are also going to be wonderful and great surgeons. The dedicated clinical team that I speak of that helped us develop a program of excellence in robotic multidisciplinary surgery is Dorothy Kreinbring and Susan Arnsdorf, who started our robotic program at the Wisconsin Heart Hospital in Milwaukee. And when it came time for me to move to Chicago, they agreed to come along and help it make it a smooth transition, both in the OR and in the clinic. Mackenzie Rupert joined and was essential in the OR as well. And finally, my current team of Brooke Patel, Caitlin Grady, Sharaka Coleman, Wani O, and Ruth Buckner, who continue to amaze me every day in their dedication to the cause and their commitment to our patients. This, in addition to our whole cardiac OR nursing staff, as well as our perfusionists and our anesthesia team. As we all know, it takes a village. Every one of these individuals is important in creating a successful program, and I dare say more important than the surgeon. And finally, to my family, my parents who taught me patience and perseverance and allowed me to explore the space in science and in sport. My sisters, Suhair and Hanan, who were a constant support system throughout our childhood and into adulthood. And to my immediate family, my wife Gigi, who weathered my busy schedule and supported my evolution in cardiac surgery with independence and grace, providing a steady hand and bringing up our two young boys almost single-handedly while pursuing her own career. And to those two young boys, Barhumi and Zaki, Ibrahim and Zachariah, who are now successful young men in their own right, and who have kept me grounded growing up and were always up for an adventure and a challenge. Dear colleagues, it is great to be with you in such a historic city, Istanbul, which sits at the crossroads between East and West, a city that blends history, culture, and geography in ways unmatched by any other city in the world, in my mind. This is a first for ISMICS, having our annual meeting outside of North America and Europe proper, in an attempt to realize the true international nature of our title and our mission. And I could not think of a better location for us to meet. I will hope that you have carved out some good time to explore the riches of this great city that served as a capital for three major empires, Byzantine, Roman, and Ottoman. It's alive with history, energy, and innovation, yet deeply rooted in tradition. So I encourage you to explore it widely. We have exceeded our previous registration numbers for an annual meeting this year, and I would like to thank all of you for making the effort to join us and submit abstracts from places as far away as California, Japan, Indonesia, and Colombia. ISMICS is a unique society, created in 1998 by pioneers, some of whom are in this room today, either physically in person or virtually through their mentees. It was created as a meeting place for like-minded surgeons interested in alleviating the invasiveness and pain of traditional cardiothoracic surgery. While most other societies were focused on maintaining the status quo at that time, ISMICS was busy pushing the envelope of less invasive surgery in things like off-pump coronary bypass, small access valve surgery, and eventually robotics. It took a couple of decades, but other societies have now followed in our lead and incorporated sessions on these topics in less invasive surgery, taking heed of the famous quote by Graff, "In times of profound change, the learners inherit the earth, while the learned find themselves beautifully equipped to deal in a world that no longer exists." I'm not sure people know this about me, so it may come as a surprise to you, but I'm a bit passionate about robotic heart surgery. Ever since I got my hands on my first Da Vinci S robot in 2006, I knew that this was a technology that I needed to incorporate into my surgical practice. I had already committed to small incision valve surgery several years prior in 2002, and committed to beating heart coronary surgery a couple of years before that in 2000. My dream, however, was to offer my patients totally endoscopic, beating heart, coronary artery bypass grafting, and I knew the minute I started moving the instruments on this device that it was the only way to achieve that goal. as Sir Arthur C. Clarke, a scientist and science fiction writer who wrote the script for the 1968 movie 2001: A Space Odyssey, famously said, "Any sufficiently advanced technology is indistinguishable from magic." And I felt that the robot would allow us to do magic. Another element in this vision was an anastomotic coronary device, but I was already onto one of those, and more to come on that topic later. My unofficial theme for this year at ISMICS is robotic cardiothoracic surgery. It is time. In this year, we had a series of robotic cardiothoracic webinars leading up to the annual meeting on topics ranging from robotic coronary, mitral and atrial fibrillation surgery to updates on robotic thymectomy, complex lung resections, and surgery for tracheomalacia. Our webinar moderators and panelists deserve a huge amount of credit for taking the time out of their Saturdays to put on these programs in the interest of disseminating their knowledge in robotic and less invasive cardiothoracic surgery to colleagues and trainees all around the world, all in the spirit of the mission of ISMICS. So thank you very much. Stan Alger and our PRI team also deserve credit for keeping these webinars coming and on track for a large, live, virtual and online audience. Dear colleagues, our field has witnessed a rapid evolution in technology and technique over the past few decades. Among the most transformative developments is the advent of robotic-assisted heart surgery, which promises reduced invasiveness, enhanced precision, and quicker recovery. However, the path to integrating robotics into complex heart procedures has not been straightforward. When first thinking about what to say to you in my address, it was not clear what my message should be. And then I made my annual pilgrimage to the International Coronary Congress in London. And it became quite clear what my message to you should be. I get invited to speak at meetings, and I have surgeons visit my OR from all over the world to talk about one thing and one thing only, and that is how to do robotic heart surgery and how to make it successful. So I figured I would try to articulate a message focusing on three elements that I think are the most important in this endeavor: passion, persistence, and patience. In our profession, passion is necessary to achieve the goal of serving our patients with the most effective and least invasive cardiothoracic surgical procedures in a specialty traditionally known for its big cuts and maximal invasion. Moreover, passion is required to persevere through the challenges that inevitably accompany any major innovation. We must stay committed to the vision of better outcomes and willing to face uncertainty and criticism as we introduce new procedures. The magnetic draw of making surgery safer and less traumatic continues to motivate teams, even when studies, resources, or support might be lacking at first. Persistence, whether it be in training and preparation, engaging with industry, or pushing through the challenges and difficulties, is a must for the success of any high-minded endeavor. The introduction of robotic surgery into the cardiac operating room is not an overnight accomplishment. We and our teams must master intricate equipment, develop new hand-eye coordination, and adopt novel workflows. It can take years for a skilled heart surgeon to become proficient in robotic techniques, a process requiring humility and considerable patience. Progress also depends on waiting for clinical and institutional readiness. The evidence base for robotic heart surgery has needed years of study and will need more. Regulating agencies and medical societies should and do require robust data before changing standards of care. In some cases, we must often wait for hospital administrators to approve new equipment purchases or fund intensive training programs for the entire operating team. Furthermore, integrating a robotic program can create scheduling and staffing challenges, all of which require measured deliberation and problem solving. And finally, patience is an extremely valuable asset in achieving the most challenging of goals, especially when the task is complex or the outcome might not be easily visible to the operator. Patience is essential in the operating room itself. Robotic heart surgeries often take longer in the early stages of the program, while the surgeon and the team refine their techniques and troubleshoot technical complications. Even experienced teams sometimes encounter unexpected anatomical variations or minor system malfunctions requiring them to pause, assess, and proceed carefully. That happened us a couple of weeks ago. So let's dissect each one of these separately. Persistence might be the most critical quality tying this journey together. The road to establishing a robotic cardiac surgery program is lined with obstacles, including learning and adopting a new complex interface with potential early equipment malfunctions, institutional inertia, and patient safety concern. We in this field have often faced repeated doubts, both internally as procedures faltered or took longer than expected, and externally from skeptical peers and limited patient referrals. True pioneers persist in advocating for change, assembling interdisciplinary teams, and championing the value of new techniques. We accept that progress is incremental, measured in small improvements, successful cases, and gradually increasing acceptance from a wider medical community. When unforeseen complications arise, persistent surgeons learn from their setbacks instead of abandoning the endeavor. An imperfect early outcome does not necessitate totally abandoning the device or the technique, but rather refining it and improving upon it. Continued professional development is another hallmark of persistence. The landscape of robotic technology evolves rapidly, requiring us and our teams to participate in ongoing education, simulation, and hands-on workshops. The most successful programs are driven by individuals who constantly strive to improve, adopt, and expand their skills to serve their patients better. The spread of robotic mitral valve repair exemplifies the interplay of these qualities. At first, only a handful of centers perform this complex procedure robotically, largely due to higher costs and technical demands and the need for supreme accuracy. Through passionate advocacy, patient mentorship, and relentless refinement of the technique, early pioneers demonstrated excellent clinical outcomes, ultimately influencing guidelines as well as teaching surgeons and increasing the adoption of robotic approaches worldwide. Randy Chitwood and Doug Murphy come to mind. Passion is the driving force that inspires us to venture into uncharted territory, challenge established norms, and continuously pursue better ways to care for our patients. In the realm of cardiac surgery, this passion is often fueled by a profound desire to reduce suffering, minimize risks, and improve outcomes for individuals facing life-threatening heart conditions. The emergence of robotic heart surgery is a direct result of such passionate commitment to progress, and as a result, the continued evolution of the clinical landscape, including the evolution of medical guidelines. I like to quote one of my colleagues who said, "Guidelines were made to protect patients from bad doctors, but good doctors were made to protect patients from bad guidelines." Many early pioneers in robotic cardiac surgery were motivated not by financial incentives or personal convenience, but by the vision of a future where heart operations could be performed with smaller incisions, less pain, faster recoveries, and fewer complications. Our willingness to invest countless hours mastering unfamiliar systems, attending workshops, and collaborating with engineers set the foundation for today's advancements. This passion also manifests in the dedication to patient-centered care. Robotic technologies promise to lower infection rates, reduce blood loss, and shorten hospital stays, and we see that all the time in published evidence. These present significant benefits to the patient's quality of life when they are undergoing major surgeries. With passion, we see beyond the benefits to the patient's quality of life, and we immediately challenge and focus on these long-term improvements, often becoming tireless advocates for changing the status quo. Our determination motivates us not only to learn, but also to teach. We train colleagues, share techniques across borders, and passionately present our early results at scientific meetings to inspire others. Furthermore, passion in robotic heart surgery means maintaining a mindset of curiosity and constant learning. Innovators are eager to participate in trials, contribute to research, and refine their approaches continuously. They seek out collaboration not just among surgeons, but also with anesthesiologists, OR nurses, biomedical engineers, and IT specialists, because they truly believe that only a collective effort can achieve breakthroughs that otherwise would be impossible alone. Finally, passion helps surgeons overcome the psychological barriers associated with risk, novelty, and failure. Introducing a new technology into a high-stakes environment like cardiac surgery can be daunting. Only those truly passionate about advancing the field are willing to stand at the forefront, accept the initial setbacks, and use them as stepping stones towards eventual success. Without this burning drive, robotic heart surgery would likely have remained a curiosity rather than becoming a life-changing reality for many patients around the world. Patience is an indispensable virtue entering the world of robotic heart surgery. This field is characterized by its complexities, both technical and organizational, and they require a long-term commitment to gradual, often incremental progress. First and foremost, surgeons and teams can face a steep and sometimes frustrating learning curve. As we all know, even accomplished cardiothoracic surgeons well-versed in traditional open procedures must acquire a completely new set of motor skills and spatial awareness when using robotic systems. The dexterity required to manipulate the robotic instruments remotely while viewing a magnified 3D display contrasts sharply with the tactile feedback and the direct visualization offered by open heart surgery. Early in the process, procedures that normally take 3 or 4 hours might stretch well beyond that, testing the patience not only of the surgeon, but also of the entire operating team. It may take dozens of supervised procedures and countless simulation hours to master the nuances of operating without robotic platforms. This patience is essential, since a rushed and a careless approach could jeopardize not only patient safety, but also the success of the entire program. And the patience is not just for the surgeon alone, but the patience of the surgeon, the remaining members of the team, especially the tableside assistant, where you basically create 2 brains and 4 hands doing one task. Beyond the operating room, patience is also required in managing the pace of institutional change. The introduction of robotic heart surgery involves far more than a single surgeon learning a new technique. Entire hospital systems must adopt. Administrators need to be convinced of the value and the cost effectiveness of purchasing expensive equipment, and operating room staff must receive new training, and supporting teams from anesthesiologists to perfusionists must acclimate to new workflows. Scheduling procedures, coordinating equipment, and resolving logistical hurdles all take time, sometimes resulting in canceled or delayed cases. Surgeons must patiently navigate bureaucracy, answer questions, assuage concerns from colleagues who may be skeptical, and often advocate repeatedly for the necessary resources. One of these resources, in my estimate and experience, is a dedicated and consistent team of professionals with whom we must have the patience to train and see through the early phases of their learning process. Patience is also critical in the gradual accumulation of clinical evidence. Early adopters of robotic cardiac procedures often must wait months or years for outcomes data to mature, so that the benefits, such as reduced recovery time, less pain, and fewer infections, can be demonstrated scientifically. As most people in this room know all too well, many groundbreaking innovations are initially met with skepticism. It takes repeated presentations at conferences, publications of well-designed studies, and the endorsement of relevant medical societies before new techniques, such as robotics, become accepted as standards of care. Our ISMICS society has been and continues to be a haven for such presentations and discussions from early on. We have led the charge in providing the environment in which surgeons and teams have the freedom to discuss these topics until the broader community, and as importantly, the regulatory bodies, start to catch up with the innovation. Another extremely important manifestation of patience is within the operating room. As each procedure requires patience in the moment, robotic heart surgery sometimes involve meticulous, time-consuming steps, such as delicate dissection or precise placement of sutures in hard-to-reach parts of the heart. For example, in TCAP, what I sometimes affectionately call the dark side of the heart. A single episode of bleeding or an unexpected anatomical variation demands composure and methodical response rather than impatience that might lead to mistakes. In summary, patience in robotic heart surgery manifests at every stage, in training and skill acquisition, building institutional support, gathering scientific evidence, and the careful execution of each case. This patience creates a stable environment in which innovation and patient safety can coexist. A balancing act, to be sure, that is essential for the continued growth of this remarkable field. In the evolution of robotic heart surgery, persistence is often the trait that eventually determines success. The journey is rarely smooth. Surgeons and surgical teams face technical hurdles and skepticism from colleagues, failed early attempts, and institutional resistance. Yet, it is through relentless resilience and continued effort that robotic heart surgery has moved from a bold idea to a standard for some procedures at leading centers. The initial operations took nearly double the time compared to conventional approaches. Technical glitches with the robot, communication difficulties among staff, unfamiliarity with both the technology and the setup frequently led to delays and intraoperative challenges that forced a relatively high percentage of conversion to open surgery. Rather than let these setbacks undermine the program, the pioneers of our field debriefed after each case, refined their protocols, insisted on more team training, and persisted through the anxiety and the occasional self-doubt. These attitudes and continued efforts paid off, as robotic cardiac surgery is distinctly on the rise with increasing adoption worldwide. Persistence is not limited to intraoperative issues. It is also required to overcome skepticism from fellow clinicians and hospital administrators. Many early robotic surgeons reported significant pushback from peers who doubted the necessity or the safety of the technology. I and others recall being told that our procedures were impractical and sometimes even dangerous. Yet convinced by excellent early patient outcomes and incremental improvements, we continue to refine the approach and collect the data, ultimately publishing results that are continuing to shift perceptions. Robotic programs also often struggle with financial and logistical challenges. The initial investment for a robotic system can be quite expensive, and billing codes may be unclear or unsupportive. How many of us recall being told by insurance companies that our procedures were quote-unquote experimental and therefore would not be covered? Some hospitals, after poor early outcomes or a lack of clinical volume, consider discontinuing their nascent programs. Persistent surgeons, however, built alliances with their administrators and demonstrated the long-term value of robotic surgery, ranging from shorter hospital stays to quicker patient return to daily activities. In a hospital such as ours, with 100% capacity, there's nothing administrators like more than the ability to fill a hospital bed with a second patient because the first patient was discharged 1 or 2 days after major heart surgery. When my administrators realized that our patients were going home on average 2 days after surgery, and in many cases 1 day after coronary bypass or mitral valve repair, they were all in. Even today, as technology advances, there is a persistent need for ongoing education and quality improvement. For example, when a new generation of the Da Vinci robot was introduced, experienced robotic teams had to once again learn a new system, adapt to updated tool sets, modify their workflows. Recognizing these hurdles as opportunities for growth rather than barriers, persistent teams have remained at the forefront, driving the field forward for the benefit of our patients. In summary, persistence in robotic heart surgery can be seen in surgeons who return to the operating room time after time, refining their craft after each case. Surgeons who advocate consistently for better resources and who turn criticism or setbacks into fuel for progress. These persistent efforts have not just advanced the technology, they have changed the possibilities of cardiac care for thousands of patients around the world. Dear colleagues, beating heart TCAP is probably the procedure most likely to be associated with my name. And if I have a tombstone when I die, those words would probably be engraved on it. Although if you ask my OR team, sitting right over there, the quote, lungs down and disconnected, may be more likely to be the engraving, because it's probably the most common phrase that I use. I'm not the first person to do the procedure. There are pioneers here that I learned from, Sudhir Srivastava and Johannes Bonatti, inspiring me to do this operation, and for sure I will absolutely not be the last. For a time, however, I believe that I was the only one doing it while relying on a robotic system that was fast becoming outdated with an ever-diminishing supply of instruments. So for those of you who've been wondering all these years, did I buy all the stabilizers? You bet I did. I bought as many as I could. When Intuitive Leadership took the decision not to make an epicardial stabilizer for the Gen 4 XI robot in 2014, the writing was on the wall. When Sal Brogna and Bob DeSantis, executive leaders at the company, came to visit us in Chicago in 2018 to inform us that the SI EndoWrist stabilizer would no longer be produced, ever, it took the wind out of my sails. This decision was based on poor adoption of beating heart TCAP over the 10 years prior, since the introduction of the stabilizer in 2008. And the inability to justify the costs of third-party vendors making the components of the device for a very, very small market. Me and Johannes. TCAP was a big portion of my practice. And this would be a major impediment to continuing the program. It made me feel like we had failed in the mission to train enough surgeons to do this procedure, and that it was too complicated of an operation to get beyond the early adopter phase of any innovation. There was, however, a small silver lining to this massive cloud. I was told that the company had a warehouse full of stabilizers, and I was welcome to purchase as many as I wanted. We were all welcome to purchase as many as we wanted. And you know what? Purchase them I did. I got the approval from my hospital administrators to purchase over 600 procedures worth of inventory and to continue our very successful TCAP program at the University of Chicago Medicine, a program that they did not want to see go away. Given that the disposable components of these stabilizers had only a 2-year shelf life, and we were purchasing a 5-year supply of instruments, we had to do some fancy negotiating with our infection control team to allow us to re-sterilize them after the expiration date. This all took place thanks to our persistence and passion in convincing all of the stakeholders of the importance of continuing this work. Another major transition occurred around the same time when our world was shaken up by the gradual disappearance of my beloved coronary anastomotic device. I had begun my TCAP journey in 2007 using the Cardica Flex A distal anastomotic stapler after becoming very comfortable with stapling the coronary artery in hundreds of open OPCAP procedures. The transition to totally endoscopic coronary bypass was made much easier using this device, and my learning curve was rendered much less steep, allowing me to move quickly to routine multi-vessel robotic TCAP. In 2018, and after over 500 TCAPs using this device, I was sadly informed that the company that had purchased the technology was planning not to continue to manufacture the device. Another blow to my TCAP practice. But what to do in the face of adversity in something we are passionate about? Well, we persist. We find another way. We decided to move to all sutured anastomosis in all cases and didn't really skip a beat. It helped that even when we were doing the majority of the cases with the anastomotic stapler, we would still use sutures or even titanium clips in some situations. So transitioning to doing all of the grafts with a short double arm Pronova stitch did not take too much time. Again, passion and persistence. Expanding our robotic program to include all different kinds of procedures came early in my robotic evolution. In the beginning, I felt that the robot would only be useful in allowing me to do endoscopic coronary surgery. However, I quickly realized that my approach to port access valve surgery could be improved upon using the robot, and that I would also be able to offer it to a larger group of patients. We quickly incorporated robotics in mitral valve repair and replacement, and in addition, we focused on building a robotic heart surgery program of excellence, not only in coronaries and mitrals, but also in arrhythmia surgery and more. A paradigm shift, if you will, from a single procedure robotic program to a multi-spectrum robotic program. An exciting journey in that context was that of robotic AVR. We formed a robotic AVR working group in 2010 at the STS meeting under the auspices of Intuitive Surgical. Later on that same year, I did my first one in 2010 using the 3F valve from Medtronic. We realized at the time that a sutureless valve would probably be beneficial, and we patiently waited until one became available clinically in the United States, and we persisted, and after multiple cadaver experiments in the lab with colleagues, some of who are in attendance here, we were able to make it a clinical reality, and we did our first sutureless robotic, totally endoscopic aortic valve replacement in 2018. And we continue to evolve and innovate. This morning we heard about a novel approach to sternal sparing surgical AVR going through the neck of all places. Using a transcervical robotic approach has the promise of producing a non-opioid surgical AVR procedure. When I first heard about this procedure from Fraser Sutherland, who was mentioned this morning, about a year and a half ago, we were already doing robotic endoscopic AVR through small incisions, non-spreading in between the ribs. But this innovation had the potential to be even less invasive. So we went back to the lab, to the cadaver lab, and we explored it with Fraser and Danny Ramsey and others. It took the bold leadership of young Dr. Kopervinak to actually execute this approach clinically in Cleveland. And after presenting it in the late breaker at AATS a couple of weeks ago, he graciously agreed to come and share it with us here. This is the type of innovation that belongs in ISMICS. To be sure, this type of innovation is not necessarily only possible with robotics. But in my mind, why deny ourselves and our patients the benefit of the latest technological advances in surgery and the ability to bring these procedures to the largest number of patients? Robotic systems today have revolutionized all surgical subspecialties. They are not merely devices equipped with articulating 8mm arms, wielding non-sensing instruments, and providing superior visualization. Indeed, they are much more. Consider the digital environment created by today's systems that can not only measure, but also record, tabulate, and report back the kinematic movements of every instrument, allowing for an ongoing assessment of safety and proficiency, not only in the operating surgeon, but also for training junior surgeons. As Dr. Richard Satava, a pioneer in robotics and one of the first adopters of the technology, said, "The robot is not a machine, but rather like an information system which could integrate all the capabilities: telecommunications, remote imaging, computer-enhanced manipulation, image acquisition, and guidance." His words have now been realized in the success of telesurgery around the globe. And importantly, in several recent telesurgical cardiac surgical procedures, such as the one here by our good friend Dr. Srivastava and our Aram speaker, where he operated from New Delhi to Jaipur on a patient who required coronary bypass surgery. And we will hear much more about this on Saturday during his talk. Even the elusive tactile feedback problem that robotics has had since inception, the biggest criticism of robotics, but you can't feel it, is being slowly improved upon on the new robotic systems with the introduction of something called forced feedback, as you see here. It's still not available for the majority of the instruments, especially the instruments for cardiac surgery, but that will be soon to come at this pace of evolution. I still maintain that I don't need it for my cases, as Surf is nodding his head. He doesn't need it either, because we've done thousands of cases and many, many years of this. I've developed a strong sense of visual haptic feedback over the years. But maybe I do, and I just don't know it yet. I need it in a different form. On a personal note, I had to have abdominal surgery this year, and it required a rather large laparotomy. You can be assured that I looked for a robotic surgeon to do it. But one of the reasons I was given to the contrary was that this specific surgery required significant tactile feedback. Even the most experienced robotic GI surgeons did not think it was a good idea, and they recommended that I have an open operation. Ironically, my surgery showed me that we still had ways to go. We still had a ways to go in making all of surgery totally endoscopic. So even if I don't think I need tactile feedback as a surgeon, perhaps I need it as a patient. So what about those anastomotic devices I promised to come back to? This is what the number of patent applications for anastomotic devices looked at the turn of the century. It was fueled by the widespread desire to make coronary bypass surgery less invasive with beating heart and endoscopic approaches. Unfortunately, this has not come to bear. And once there were issues with some of the early versions of these devices, St. Jude's symmetry device comes to mind, surgeons' appetite for continuing was drastically reduced. Those of us who desperately wanted these devices to work out had a tough time convincing our colleagues that it was the way to go. The only distal coronary anastomotic device to make it through the regulatory hurdles of the day was the Seaport coronary stapler from Cardigan, which we had the opportunity to use extensively, as mentioned before. Despite a little bit of a learning curve related mostly to the loading process, we found it to be very successful in creating a reliable end-to-side anastomosis between an arterial or venous conduit and the coronary artery. This is based on clinical and patency evidence with thousands of anastomoses in our hands and others, many of which were studied angiographically in the course of hybrid revascularization. Could the device have been better? Of course it could. All devices can be better. But in my mind, it wasn't too bad as it was. It allowed me to do an endoscopic operation, single vessel, multi-vessel, you name it, on a beating heart with no cross-clamp. The market, however, did not look at it that way. It did not look favorably on a device that wasn't a slam dunk easy device for the use of a wider adoption, and therefore the device did not survive. I last used it in 2019. Currently, there are no commercially available distal coronary anastomotic devices on the market. The only two being developed that I've had the opportunity to work with and use in the lab come out of the Netherlands. One with clinical and the other with preclinical applications thus far. The Ilana laser device from AMT, which is shown here, is very innovative and applies a laser probe in creating the arteriotomy in both the coronary and the conduit. And we're going to hear some angiographic follow-up in the next coronary session tomorrow on this interesting device. And the promise is that it will revolutionize sternal sparing coronary surgery. The Octacon device, also from the Netherlands, from the company Octovascular at the University of Utrecht, is in preclinical trials, and we had the opportunity to use this in our lab at the University of Chicago with a robotic approach. And both of these devices are very innovative and continue to tell us that there is still interest in developing these devices. The third device, the Nadi coronary stapler from SSI, promises to be a robotically applied device that we will hear more about on Saturday. Dear colleagues, over the last 25 years, we have come a long way in robotic cardiac surgery, but we have much further to go and much more to learn on behalf of our patients. The technology has matured. The systems have become much more sophisticated and their capabilities much more refined. Robotic industry has finally recognized the need to incorporate instrumentation for cardiac surgery in the development of their new systems. They have prioritized this as a result of, among other things, our passion, patience, and persistence. As robotic cardiac surgeons in continuing our work and advocating for our patients, we cannot let this moment pass without jumping in and availing ourselves of this technology. We need to work with smart bioengineers to develop new instruments we need to help us perform our best operations, and yes, that includes a new coronary stabilizer. Other surgical specialties have figured this out to a large extent, and they've incorporated robotic training in their residency programs. Our thoracic colleagues amongst us can tell us exactly what happened when the stapler was adopted to the robotic arm. You can see in this graphic, there's a huge difference between pre-2015 and post-2015. The curve goes almost straight up. Why? Because a stapler was attached to the robotic arm. This can be true as well in coronary surgery, as we have talked about a lot. We are moving into a new age of technological advances. With the advent of artificial intelligence and large data models, who knows what we'll be doing 10 years from now? I truly hope that it will not be valve sternotomy surgery or cabbage sternotomy surgery with a lima and 3 veins. We can do better than this for our patients. I know I'm preaching to the choir of minimally invasive cardiothoracic surgery at this meeting, but I believe our specialty can catch up to meet those technological challenges and advance halfway. And I think now is the time. Thank you for being advocates of less invasive surgery and for coming to Istanbul to attend our annual meeting and for your attention. And thank you very much to our sponsors who have created a wonderful environment for us to continue to learn and collaborate and innovate in the betterment of what we can do for our patients. I wish you a very successful and invigorating rest of the meeting. Thank you very much.